A very good evening to everyone. Myself, Professor Shomi Mojumdar, Department of Business Administration from Future Institute of Engineering and Management. Respected teachers, distinguished guests, and my fellow participants, it is my privilege to welcome you all to this session on a topic that perfectly blends healthcare with cutting edge technology, artificial intelligence in diabetes management. Diabetes, as we know, is one of the most widespread chronic diseases affecting millions of people worldwide. Managing it requires constant monitoring, timely decision making, and personalized care tasks that can often be overwhelming for both patients and healthcare professionals. But today, with the rapid advancement of artificial intelligence, we stand at the threshold of a healthcare revolution. The integration of AI does not just make diabetes management more efficient, it makes it more intelligent, proactive, and patient centered. With continuous innovation, AI has the potential to reduce complications, improve quality of life, and even pave the way toward preventive care. As we explore this fascinating intersection of technology and healthcare, let us remember that the ultimate goal of AI in diabetes management is not to replace doctors, but to enhance human judgment to make care more accessible, accurate, and compassionate. Now, I am going to introduce our today's speaker. It gives me immense pleasure to introduce today's distinguished speaker, Dr. Shambho Samrat Shamazdar, a scholar, clinician, researcher, and innovator whose remarkable contributions have greatly advanced the fields of pharmacology, endocrinology, and diabetes care. Dr. Shamazdar, an MBBS, MD, and DM in clinical pharmacology with a gold medal, is a shining example of excellence in medical science. He also holds a postgraduate diploma in endocrinology and diabetes from the Royal College of Physicians, UK, a fellowship in respiratory and clinical care from WBUHS, and a diploma allergy, asthma, and immunology, also awarded with a gold medal. Dr. Shamazar has an outstanding academic and research record, having published over 148 articles in indexed medical journals and contributed more than 80 book chapters to national and international publications. He is also the author of several acclaimed medical books, including Competency-Based Practical Pharmacology, Diabetes in Practice, Artificial Intelligence for Physicians, and Foundation of Allergy Practice, among others. He is a fellow of the Indian Pharmacological Society and fellow of Diabetes India, and was recently recognized by Governor for his outstanding contribution to research and publication in the SEP India Chapter 2024. Today, we are truly privileged to have him, such an inspiring leader who not only bridges the gap between medicine and technology, but also pioneers innovation in patient care. I'll not take too much time. Dr. Shamazar, now I request you, please start the session. So over to you, sir.
Thank you, madam, for giving this uh, introduction to this topic. And my screen is visible, and the slides are also changing, right? Can you please confirm that?
Yes, yes, it is changing.
Okay, so today's topic is artificial intelligence, how we use artificial intelligence while managing diabetes. And at the onset, we need to think or consider that India is currently the diabetes capital of world, but we want to become the diabetes care capital of world. And very unfortunately, it is true that only 20% of our patients are achieving their glycemic target. So with so many treatment we have, with so many professionals we have in this country, till we are achieving only 20% of our target. So this is why we need to do more work in this field, and we need a good handshake between healthcare professionals and technology professionals so that this gap can be minimized. So these are few data we can see, uh, which is telling why the traditional systems are failing. So we have a fragmented care ecosystem. There are siloed providers, no unified data. We are writing so many drugs, but what actually happened to our patient, uh, that information is lacking. And most importantly, while dealing with any chronic therapy, adherence is an important area where the behavioral counseling matters and how the behavioral changing tools need to be utilized. That we need, that is an important area for our work. And of course, till date there is a shortage of diabetologists. Even 1:20,000 ratio is there in many regions. And as we talk about diabetes management, where monitoring is an important uh, strategy to improve the outcome. If we have manual monitoring system, that always lead to fatigue, and if we have too much data but not enough insight, that is very unfortunate. So in nutshell, what we can conclude, diabetes is complex, data heavy, and demands continuous vigilance. And that is where artificial intelligence excels. I think all of you are the technology people. You know better than us about AI. But in nutshell, what we understand AI as an umbrella and ML, the machine learning as the engine. And when we talk about deep learning, it is a turbocharged version in your language only. To explain it in a little bit more, the artificial intelligence is that broad field of creating machines that mimic the human intelligence, perception, reasoning, learning, and decision making. When we go to the machine learning, that is a subset of AI where machine learns from data to make predictions or decisions without explicit programming. And now when we talk about deep learning, that is a type of machine learning using neural networks with many layers to process the complex patterns in large data sets like images or speech. So what we want, as the respected chairpersons had mentioned, we want to augment the care. So this is a traditional workflow when we see our patient with some lab reports, and according to that, uh, clinical evaluation and correlating with the lab parameters, we plan on our diagnosis and therapeutics. But what we actually want, if we have something to be noted as artificial intelligence augmented workflow. So with patient, if we have doctor with artificial intelligence, so that can help us in diagnosis and also the optimizing the therapeutic plan. And again, that will go back to the patient, and that information again come back to the system. So we will have better and better response in future. So this is why we want artificial intelligence augmented care rather than the persisting traditional clinical workflow. So the most important part is artificial intelligence is not going to replace doctor, but it empowers the doctor with deeper insights in a faster manner. And very importantly, we need to acknowledge AI is not equal to automation. Rather than it is a augmented clinical intelligence, amplifying the human expertise with predictive and data-driven support. So if we check the role of artificial intelligence in diabetes, be it public health interventions, prevention, lifestyle, and dietary management strategies, enhancing the clinical decision making, how they inform and refine the healthcare professional decisions, then how we can engage patient, their self-management, developing predictive models. So as we know, diabetes progression and treatment response need to, if we predict it early and we can take certain decisions, so that could help in prevention of different type of atrocities. And if we have the monitoring system properly, for an example, the real-time glucose monitoring and alerts, and that can help us in titrating the dose of insulin. So apart from that, the diagnostic and imaging technologies, different type of medical imaging is important in diabetes care. For an example, the retina examination, and very importantly, we have multiple drugs in our hand, but how to optimize them, how to optimize their dose, how to titrate the insulin dose. If in these all sectors, artificial intelligence can help us that ultimately improve the patient outcome. This is an important model by the virtue of AI we are using now in our day-to-day clinical practice, uh, by which we are getting a whole body digital twin. And this is a live artificial intelligence model of individual's metabolism, because we know our metabolism is not same in in each human physiology. So just like that, uh, all dose of drug does not fit all. So it should be personalized. So same thing, the metabolism is different in different person. So with the virtue of different daily signals, be it some sensor data, blood data, medication information, behavioral data, food data, and socioeconomic data, uh, we can prepare one digital twin, and that could help us in precision nutrition, precision medication, sleep, activity, and breathing exercises. So what is the evidence level with this digital twin innovation? This is a important 1 year randomized control study. They had used continuous glucose monitoring, certain wearables like smartwatch, and logs to model users' metabolism. So this particular randomized control trial had shown in the digital twin arm, there was almost 2% HbA1c drop, whereas in the standard care without digital twin, it was 0.2%. Not only that, the body weight was almost 8 kg loss in the digital twin arm, and more than 10% weight loss, which is one of our desired outcome, was there. Almost 42% of the population who were on digital twin. BMI reduction was there. Waist circumference reduction was there, almost 10 centimeter. And most importantly, at 6 months, the adherence rate was almost 90% in the digital. So in with this information, what we can say, if we combine artificial intelligence with human clinician oversight, that would lead to this clinically meaningful solution, providing effectiveness and ensuring safety. We had also done, I was a part of this particular study where we saw this digital twin in managing hypertension among type 2 diabetes. So we know that in diabetes management, the ABC control is important. A for A1C control, B for blood pressure control, and C for cholesterol management. Now, when we talk about blood pressure control, this particular randomized control trial, what we had shown with the help of artificial intelligence, which enable this digital twin technology more effective than the standard of care in reducing blood pressure. And also we can see from this slide that how the need of antihypertensive therapy was reduced. And almost a good proportion of our patients were reaching the hypertension remission and normal albuminuria. So, through urine, if the albumin is coming out, the microalbuminuria, which is a concerning sign in type 2 diabetes, they are the predictor of diabetic kidney disease and with certain fatal outcome, both cardiovascular and renal outcomes. So if we make them normal albuminuria with the help of this digital twin technology, that is really fantastic. And this had been shown in type 2 diabetes patients who were suffering from hypertension. Almost 233 patients were on this digital twin enabled precision lifestyle intervention. And this was one of the paper on digital twin technology that had been published in ADA. And in this particular study, they had shown the remission. So among these 233 digital twin participants, 207 completed a minimum of 6 months of the intervention, and 64.3% achieved sustained remission at 18 months, which is remarkably good. And we always talk about the randomized control trial, but we all know that when we talk about randomized control trial, the internal validity is very high. And that is the crux of randomized control trials. But real world evidences are also important, because in real world evidences, maybe the internal validity is less, but external validity is much more. And that also tell us the real world adaptation of the particular therapeutic option. Here it is the technology. So the digital twin intervention for type 2 diabetes, it is a retrospective real world study which had shown if we combine the artificial intelligence with clinician, this synergy drives personalized and scalable care, and that improves insulin resistance quite significant. Now, coming from type 2 diabetes to another dimension of diabetes, another very important but neglected area of diabetes, that is type 1 diabetes. Here we had seen a great paper that had been published in NEJM on which was a multi-center randomized controlled trial of a bionic pancreas. So what we found, there is more time in range, more time the glucose was in the desired target, less sugar fall, and less patient burden. And after this particular study, the FDA, US FDA, that their drug regulators approved this islet bionic pancreas. And this is very important now, because we are talking about closed loop system, which can be considered as artificial pancreas, because we all know that type 1 diabetes the pancreas is empty of insulin. There is no insulin is coming up, and therefore the problem arises. But if we have these components inbuilt, that means we have a CGM who will continuously monitor the glucose. We have one insulin pump through which continuously insulin will be provided. We will have an artificial intelligence control algorithm, which is mostly an adaptive machine learning based models. It is the real-time adaptation. So what happened in type 1 diabetes? We need to take 4 insulin shot. One insulin is basal. We need to give it at any fixed time of a day, generally, and then 3 bolus insulin that need to be given before meal. Now, if I am taking certain carbohydrate, we need to calculate that carbohydrate, and on top of that, we need to adjust the dose of the uh, bolus insulin, and this is little difficult for our patient. But if we have this real-time adaptation by the virtue of artificial intelligence, that can reduce the load, patient load, and that will definitely help in achieving better time in range. So this is AI-powered closed loop system. What we can see, so CGM will transmit the glucose data, and the AI algorithm, they will predict and adjust the dose dynamically. They will give the information to the insulin pump, and that will deliver the insulin in real time. And not only that, with that insulin, how much glucose excursion or glucose is falling down, that will be also noted, and that information will be fed to the system, and this loop will continue. The AI algorithm will predict and adjust those in a better way. So this is not just automation, it is personalized metabolic control at machine speed. And I can share my own experience when I was there this time, the IDF, the International Diabetes Federation conferences. There is a group of people who were attending the conference suffering from type 1 diabetes. So there is a special cluster of type 1 diabetes patient. They generally visit this conference. They share their own experiences. So we met one guy who was suffering from type 1 diabetes for long. Uh, he had checked his HbA1c, and his HbA1c was that time 6.3. So we were very happy because we have a experience that to reach HbA1c for a type 1 diabetes below 7.5 is a great task. And if it is below 7, we are more fearful on the hypoglycemia, that is the sugar fall. But that guy is 6.3, so that we were very happy. But that guy was not happy. He became a little angry with that HbA1c report, because he was telling after 6 or 7 months, my HbA1c become more than 6 now. We were astonished. Then we found that the patient was using this closed loop system. And with this closed loop system, the patient is, the time in range is almost 95%, 96% like that. So this is the beauty of technology. If we have a good marriage with technology, that the outcome is always better. So this is what our experience in IDF, and actually we can anticipate the unseen, because as here we were mentioning how to predict the hypo and hyperglycemia, because that can prevent the complication in a both way. And especially this is important for the pediatric patient uh, who are at the verge of hypoglycemia risk, and also those patients who are having multiple episodes of nocturnal hypoglycemia. So if we have machine learning plus continuous glucose monitoring, this could be a powerful duo. We have a continuous glucose data as an input along with insulin dosing, meal timing, their activity. And with that, these predictive models will forecast the blood glucose levels at least 15 to 60 minutes ahead. Depending on that, they will deliver the insulin. So if we consider this real world case of pediatric hypoglycemia, the machine learning models achieved almost 90% accuracy in predicting hypo events in children. And they had used these techniques in logistic regression, random forest. And these early warnings ultimately translated into lesser emergency room visit and improving in the quality of life. We can see here the blue line, the actual CGM data, and the yellow line, the predicted glucose, and we using the machine learning model, and that is the hypoglycemia threshold, that 70. So what we can see, almost the predicted trend dips 15 to 20 minutes earlier, and that effectively forecasts the onset of hypoglycemia before it occurs. So this is what we want. And we can say that artificial intelligence transforms this glucose monitoring from reactive to proactive care. Now coming to another spectrum in type 2 diabetes management, that is the how we can diagnose the complication of type 2 diabetes and type 1 diabetes, of course. And one of the very key important complication is the microvascular complication of type 2 diabetes, and that is diabetic retinopathy. Now, with the retinal photography and AI, using AI, with the help of other demographic medical data, ophthalmic disorders and non-ophthalmic disorders causing retinal changes, we got a very high efficacy, or rather we can say efficiency, of AI models to detect these all group of disorders. Ophthalmic disorders, if the glaucoma to age-related macular degeneration, even cataract refractive errors, and non-ophthalmic disorders also. By taking the retina, we can tell our patient that yes, you are having higher chance of chronic kidney disease, hypertension, cardiovascular disease, even Alzheimer's or Parkinson's disease. So this was a fantastic review article which had included almost more than 7,900 patient data, and they had actually shown this information. For an example, vision-threatening diabetic retinopathy, this deep learning system had an accuracy of around 95%, sensitivity of 91%, specificity of more than 95%. So this is what we want, a good handshake between artificial intelligence and the clinician. And these are a few important AI systems we can see here in this particular slide, by which we can detect diabetic retinopathy in an efficient way. And this is an US FDA approved diagnostic screening for diabetic retinopathy. So this is a compatible retina cameras we can see, and they can this robotic camera automatically captures the image and diagnose the image on the spot with no need for specialist overlay. So this had been FDA approved, and there are portable camera also, so that we can have a point of care management of this using these cameras. Now another interesting study, just having the facial textures through one mobile phone camera, we can detect the diabetes. So this was an interesting study conducted in Filipino adults, and they had used mobile phone cameras, 12 megapixel and 7 megapixel. So 30 centimeter from the face under the normal lighting, they had taken these photos. And this region-based facial texture block extraction, they had done the features filtering with Gabor filters. I think these are the technological issues which you were more conversant, and they use this different type of support vector machine or k nearest neighbor models. So this, for us, this could be a non-invasive, cost-effective screening tool. We can see the accuracy, sensitivity, specificity of this 12 megapixel camera who had used this support vector machine, which could be useful for large scale diabetes risk assessment. And it could encourage future direction for artificial intelligence assisted telehealth diagnostic. So you could do some more research on this, and you could help our country to detect diabetes early by using this type of cameras, non-invasive devices in a less restrictive environment. Coming to another end, I think we need to acknowledge the role of artificial intelligence in diabetes. It is ubiquitous, it is influential. We had shown how CGM data analytics can be interpreted easily and can be translated into better patient care. We can, using this artificial intelligence, we can have the analysis of the trends on hypoglycemia. We can predict hypoglycemia or hyperglycemia. According to that, we can have our ideal insulin dose. And then the automated insulin delivery, we had talked about artificial pancreas, the closed loop pumps, how we can adjust the insulin dose via algorithms. And we had talked about islet bionic pancreas, which had been approved by US FDA. At the same time, the artificial intelligence algorithms suggest insulin dose. They can flag the risk for clinicians. And if we talk about ChatGPT like assistants, one of our friend, they had developed a beautiful chatbots, generative AI chatbots for patient queries, their education, clinical support documentation. So time is an important factor while treating type 2 diabetes patient, or even of course, type 1 diabetes patient. So in diabetes, time matters, but as we had shown, the doctor, diabetologist, physician, diabetologist and diabetes practitioner is to patient, diabetes patient, that ratio is very high. So we have lack of time, and therefore we can use this generative AI chatbots to have a better patient understanding on their disease. But with all these good things, we need to understand few important areas, because we should not neglect the human intelligence. Because when we talk about human intelligence, it is about reasoning, empathy, creativity, and moral judgment. Yes, artificial intelligence would help us in data-driven task execution, but it lacks consciousness. It, it does not have any morality and intent. So there is always a risk of substituting human faculties for synthetic competence. So this is why we need to understand there should not be any versus human intelligence versus AI. So we had talked, when we use artificial intelligence, it is not an automation. But if we use artificial intelligence randomly, it will definitely develop automation bias. And this is an important threat to clinical decision making. So automation bias, which has a tendency to overtrust artificial intelligence recommendations and stop verifying independently. So clinicians may accept the algorithm outputs uncritically, assuming the machine is always right. and they shift the responsibility. So providers defer to AI, like the computer suggested it, instead of using own judgment. So there is the trend. And yes, we are living in this war zone now. The This is a very important quote. The very intelligence we trust to automate the life-saving insulin delivery can also be weaponized. And this is not just a glitch. This is a potential cyber lethal threat embedded in our diabetes care too. For an example, attackers predict the blood glucose response using machine learning, and this allows the creation of certain realistic but malicious insulin dosing commands. And these are indistinguishable from the valid ones unless specifically detected. So it is our role also to how we can prevent this type of attack. And this is one study we found they had done almost 47 type 1 diabetes patient and 2,25,000 or 26,000 logs from real insulin pump, and they had predicted 90% accuracy for blood glucose response enables precise attack simulation. So overdose detection is easier than underdose. Children are more vulnerable, and that detection significantly weaker. General models underperform compared to age-specific models. So this is an again important area we need to be very much careful. And another aspect of artificial intelligence, which we believe that over reliance on artificial intelligence that ultimately lead to de-skilling, and continued dependence on artificial intelligence can erode our own judgment and intuition. So when we talk about erosion of clinical judgment and expertise, it is important to note there is a good level of evidence now with skill atrophy, with automation bias and complacency. And we have diminished critical thinking now in this AI era. We are having this cognitive offloading. So critical thinking decline if we heavily use artificial intelligence that encourage the cognitive offloading the mental effort to the machine, and clinicians risk losing the habit of deep analysis instead of grabbing the quick algorithmic answers. So we have less questioning why, more accepting what the AI is telling us. So this is what we found from a very interesting study that had been published in Society's Journal. So this is another study where it was found younger participants who exhibited higher dependence on AI tools scored lower in critical thinking compared to their older counterparts. So this is why we need to be very cautious, and there is risk to patient autonomy and engagement because we are following some algorithms. So algorithmic paternalism. So AI decisions based on generalized data may override individual patient preferences. So we are risking a one-size-fits-all approach, where our goal was to not follow the one-size-fits-all approach, and there should not be any opaque logic. So black box AI tools lack that explainability. It might hurt patient autonomy by preventing the patient from making their own decision and informed decisions. Patients can be sidelined if they can't understand or questions on AI driven decision, and the very ethos of shared decision making may suffer. So educational impact is again another concern for us, how to train the next generation. There is a training dilemma. Young clinicians learning with pervasive AI may not develop that robust independent decision-making skills. So there is a risk of generation of doctors who are algorithm operators first, then medical problem solvers second, and educational imperative which need to adapt the medical training to emphasize the critical thinking, when to question why. So how we should question artificial intelligence, that skill we need to have to prevent loss of foundational skill. So this is an important thing. We need to use high-tech tools, but we should not sacrifice to for having these low-tech minds. Our brain should not become the next appendix of our body. This is very important. We need to remember. And professionally, the clinician's autonomy is at the stake. If we use AI consistently that outperform the humans, which can potentially reduce the doctor's independent authority. Next question arises on accountability and liability. So when we are using AI guided decision and leading to certain harm, it is unclear who is responsible, whether the algorithm designer is responsible, whether the clinician is responsible. And there were in legal ambiguity noted, especially when we talk about diabetes, the do it yourself, DIY insulin system, which is very useful and very much adapted by the young type 1 diabetics. That is a big question mark. Who could be held liable if some ambiguity noted? So the value of expertise is still important if society begins to value AI accuracy over human judgment. So traditional expertise and intuition of clinician could be devalued then. So this is what we were talking about, do it yourself artificial pancreas system. So what are the important challenges here? Now this adoption is rising despite no formal regulatory approval, and they are involving multiple unsanctioned integration of CGMs, insulin pump, and open sourced AI algorithms. Now, whether we can call it as an innovation or legal minefield, important question. So clinicians, developers, manufacturers, and users are all uncertain about their legal responsibilities. This was the study they had published in Diabetic Medicine. When we talk about clinician, maybe liable under clinical negligence law is always there. Clinicians always liable under the clinical negligence law. But at the same time, the software developers, parents of the patient, and the users, they face uncertain accountability and no clear product liability or best interest coverage for several actors that we found from this. So legal issues are still developing, and we need to go through them thoroughly, and we need our legal colleagues to help us in this regards. Coming to ethical implications, blindly follow an opaque algorithm that challenges the ethical duty of transparency and informed consent, and bias in artificial intelligence algorithms could silently perpetuate disparities without active human oversight. So how we can preserve the human element in care? We need to understand artificial intelligence is not equal to infallible. Advanced as it is, we need to understand artificial intelligence can have errors, bias, or oversimplify. And human insight remains crucial to catch those mistakes and tailor care. So human intelligence is irreplaceable. The clinical judgment, critical thinking, and compassion must not be ceded entirely to those algorithms. We need to use AI as a tool, not crutch. That we need to remember to maintain a healthy skepticism and always apply clinicians' oversight and context. And I think that is why this two-directional, we can say the communication is important between healthcare professionals and the technology professionals. And that is why we recently had launched one very important innovation, that is SHIFT, Synapse of Healthcare Innovation in innovation and technology in India, so that we can bring both the doctors and the engineers and this technology scientist in a same platform. So we need to prioritize the training and policies that harness the artificial intelligence benefit, while safeguarding clinicians' cognitive skill and patients' autonomy. So our educators, the education system should have a good focus on that. So there are three pillars of ethical artificial intelligence integration in healthcare. Number one, human in the loop system. So AI should assist, not replace clinical judgment, ensure override capability and interpretation ability to in all AI tools. And there should be transparent model variation. So the validation of the model should be very much transparent, open benchmarks, independent auditing, no black box logic, as we were mentioning repeatedly, especially in critical care settings like insulin dosing. And the third important pillar is the equity. So we need to design them with a diverse population in mind, avoiding the systemic bias. So underperformance in certain data uh, that is not uh, desired at all. So clinicians must not just be artificial intelligence users, they must become the artificial intelligence gatekeepers. Yes, this is an important concern, the data privacy and ethics. 81% of our Android diabetes apps, they lacked privacy policies. And we have multiple unsafe insulin dose calculators. So that is why some systems are, for an example, we were talking about these digital twin systems, which were aligning with those HIPAA, GDPR, or even the DPDP 2025. They built in this specific encryption of AES 256. These are important to note if we are developing one new tool, and there should be a pseudo anonymized, and the anonymized data, that data should be properly anonymized, and we should have a consent tools. These are the regulations across country we need to go through, because when we talk about AI, we need to know these regulations, which are different in different countries. And India also, very recently, we have DPDP, which had ensured how we should tackle the consent, encryption of the models, and the data sovereignty. We had published this paper very differently. If someone is interested, they can go through this article. This is available freely in the BPJ, Bengal Physician Journal, the official journal of Association of Physicians of India. You can type this and you can get this freely downloadable PDF. So how we should train our future diabetologists? We need to understand that AI is not going to replace diabetologists, it extends them. Medical education must include this data literacy. We need the technocrats help, the technology officials, the professionals help, and in this regard, and how we can critically evaluate artificial intelligence. And of course, we need to develop the system where human in the loop design. So this could be our vision in 22 for 23 30. So what comes next? We could have a good predictive prevention models at large scale. We need national artificial intelligence based diabetes registries and real-time feedback loops from EMRs to patient devices. So AI is not a panacea now, but it is a powerful enabler, and clinician artificial intelligence partnerships will define the next decade. Technology with human intelligence, not instead of it. This should be our cash line. So with that, we hope for this type of clinic in our near future. Initially, maybe 100 years back, this stethoscope was not there. So we have no stethoscope that time. The initial advent of stethoscope, some doctors that time may have certain restriction to stethoscope also. But now without stethoscope, we are not being considered as a doctor, and we are handicapped really without stethoscope. But maybe after 10 or 15 years, this artificial intelligence could be on our new stethoscope. Without that also, we could become less powerful doctor. So we need artificial intelligence in a way that can make us an efficient doctor. So thank you very much once again for giving me this opportunity to share my thoughts with this August gathering. Thank you. If we have any question or comment, we can take this.
Thank you, sir. Thank you for your nice session. So now we will take question for participants. Participants, you may type the question in chat box also. If anyone has any question, please type in the chat box. Sir, we have one question. Sir, in chat box, please see the questions. From Dr. Shomodi Bush, there is a question. What is the pros and cons of the AI-based method?
Yeah, I think we had discussed it in details that, of course, if we talk about the artificial intelligence in diabetes care, the pros are uh, we, we we need continuous glucose monitoring based system, and their predictive hypoglycemic capabilities. So we can use them appropriately while having AI. And then we had also discussed about the artificial pancreas, the closed loop system by which we can also help our type 1 diabetes patient a lot to reach the target in range, time in range in a better manner. And very importantly, the communication, information, that is also important for our patient, especially regarding their lifestyle, regarding the timing of their medication intake. So in that perspective also, the artificial intelligence is working very, really good. But at the same time, the cons are, of course, it can have uh, unnecessary dependence on the artificial intelligence, leading to automation bias. And as we were mentioning about the cognitive offloading, cognitive offloading is very important concern for all of us. And we had also discussed about certain security issues. Same, this algorithm can be utilized by some weapon mongers, and they can make it as weapons, and they can kill the type 1 diabetics. So that is again a very important concern for all of us.
Sir, we have few more questions in chat box.
Yes.
The next question by Sachin sir. The question is, by looking towards, can we predict the complications of diabetes in nearby future?
By looking,
By looking towards face, can we predict the complications of diabetes in nearby future?
yeah, it could be because very recently, whatever data we have, by having a good picture of the face, they had predicted in a better manner the diagnosis of diabetes. So even in your future, if we have a good data, and by that we can predict the certain diabetes complications also by taking the picture of a face. And there are certain clinical signs of diabetes complications if we go by the face. By looking at the ear, if certain lobules are more, then we can predict that this patient could have uh, more chance of having heart attack. Or if we see our sclera, then we can found that uh, just surrounding the cornea, if there is some white patches there, so in early of age, then the patient is having more chance to develop atherosclerosis. So like that way, there are multiple clinical models. If we can make them in our decision making tree, and we can have a composite AI based designing and validating models, then we can capture the picture of the face and we can detect certain complications too. As of now, we have a very good model on retina. The photo of retina we can get, if we can get, we can predict multiple disorders, different types of diabetes related complication, even non-diabetic complications also.
Sir, we have another question from Prosenjit Basu. Can a person with HbA1c 7.5 go for the CGM?
Yes, depending on the patient's condition, if a patient is on multiple insulin, the HbA1c is 7.5. So we want to see whether the patient is actually having a good time in range. This is one important area because HbA1c is 7.5%. In 3%, in 1%, it could be normal glycemic variability. In 1%, there could be very high glycemic variability. So sometimes it is very high sugar and sometimes it is very low sugar. And another person could remain mostly in low sugar reading and sometimes it is very high. So by doing CGM, we can differentiate between these three groups and we can understand what is the pattern, and according to that, we can have our therapeutic decision making. Especially it is important, CGM is important for our type 1 diabetics, but at the same time, some type 2 diabetes patient who are having brittle diabetes, like lot of glycemic variability, there we need to do this CGM.
Another question from Joydeep Nath. What is the main reason behind to become diabetic capital? What is the main reason behind to become diabetic capital?
So there are multiple causes related to our genetics, related to our dietary pattern, environmental conditions, and most importantly, our behavior, sedentary behavior. These all are actually making us more diabetic prone. So this is a very important sign, though it is not desired, but this is a sign of prosperity. Diabetes generally is a disease of prosperity. So if our country is developing, we'll become diabetic capital, but we want to become diabetic care capital. If you have more food, but you are doing less activity, this is a simple theory which can lead us to develop these lifestyle disorders, including diabetes and obesity.
Okay. Sir, again, one question from Joydeep Nath. Using AI without taking blood can be possible to detect diabetes properly? Using AI without taking blood can be possible to detect diabetes properly?
No, that is why we had shown that particular study where by having a image of face, they had detected the accuracy was very high. But I think that model also initially, to validate any model, you need to correlate with the blood sample measurement only. Otherwise, how you can develop the model. But once you develop the model with very high sensitivity and specificity, then you can go for this for mass screening. And that face recognition tool, what we had shown, that is really helpful because that had taken a good number of Filipino adults. But to validate that in our setting, we need to do our own study because our facial texture may be different compared to the Filipino model. So that is why we need our own study. And for that model, you need to do the proper way, the sensitivity, specificity analysis.
Sir, one question from Dr. Prashanta Guho. As you mentioned the dependency on AI tools, how can physicians maintain their clinical judgment and avoid over-reliance on algorithm? As you mentioned the dependency on AI tools, how can physicians maintain their clinical judgment and avoid over-reliance on algorithms?
Yeah, those, so I think that's what we had discussed during our education. We need to be very much uh, comprehensive how we should believe on our uh, own skill, the clinical skill, rather than just depending on those AI driven answers. So we need to be clinically critical over the response from the AI. Otherwise, we will be suffering from automation bias, and that will lead to skill atrophy. So that is why our medical education system need to be grown in a proper way. Otherwise, we are going to have this problem of cognitive offloading, the new terminology.
Yeah, thank you, sir. Another question from Dr. Kartian Krishnan. Can you give some diagnostic challenges using AI when compared to the conventional method? Can you give some diagnostic challenges using AI when compared to the conventional method?
Now, initially, when we are validating one system, there is always difficulties, and that is why you need to feed your system with the information, and that information, when you are repeatedly feeding your system, when your deep learning is ready, then you will get a perfect answer. Otherwise, during the beginning, initial phase, we all will have problems with the response. I think the very common example is with ChatGPT. Initially, the response of the ChatGPT, maybe 1 year or 2 year ago, what was the response from ChatGPT, and what is the response of ChatGPT now? You can see the differences, and that also depends on how you are doing the prompts. Previously, the prompt engineering is something which is a very special task. But now again, with time, a prompt engineering, the ChatGPT also can develop a good prompt for you. Initially, we were dependent on the prompt engineers. So this is why the system evolves, and with with all validation, this validation of any system, initial there will be certain uh, inertia, or we can say there could be certain problems, but with time, this system will ML will be developed in a more efficient way and give us better responses.
Thank you, sir. Thank you answering all the question. And no more question we have. So now
Yeah, Baba.
we will
Hello?
have
Hello? Yes,
Prashant
ma'am. I
audible,
had a
sir.
question. I had a question. Sir,
Sir, I yes, sir. I told you and I also texted in the group to text here. Okay, sir, you ask the question.
yeah. Sir, can you correlate diabetic retinopathy with the current scenario of the hello?
Yes,
Yeah,
sir, you
hello.
are audible. You please
Yeah,
ask the question.
yeah, sir. So, how can we correlate diabetic retinopathy? Can you explain, sir?
Yeah, I think there is one good model, and diabetic retinopathy is a model which had been gone through multiple testing. I think for last 6 or 7 years, and we
Yeah.
had good devices which is US FDA approved also, by which we can predict diabetic retinopathy.
Sir,
Uh,
can you say, sir, where from to get the live data sets right now? Actually, there are some scarcity of data set in that regard.
I think you can talk with those people who are developing. I had shown in a few slides on the US FDA approved AI models. That is, one is Aurora AI, and I
Huh?
think one is AI with Topcon, like that, which got
Yeah.
FDA approval. So you can directly contact with them, because
Actually, sir, I went down to this over here in Kolkata, Newton. I went down to this Disha, and over there I had a talk with the doctors, and they said that they are all these data are, that means
I'm lost. I'm not getting your voice. Can you please repeat?
hello, hello,
Yeah.
hello. Is there any free
No, no, no,
repository
no
data
free
set?
data. Because the data sets are not free. You have to contact with those company person, because there are a lot of privacy and confidentiality related issues. And therefore you have to talk with them. If they allow you, then you only can take those data.
So nowadays, is RoboFlow is applicable in diabetic retinopathy?
Which one?
RoboFlow?
I don't have any information on robo. We were
Okay, sir.
using this AI model, because AI,
Yeah.
because we have to use this in a those models which are approved, because in
Ha.
clinic setting we cannot use anything which is not being approved by our regulatory agencies. So that
Okay.
is why we use AI.
Okay, sir. Thank you.
Thank you.
Thank you, sir. Thank you for this wonderful session. So now we are heading to the end of this session. First and foremost, I would like to express my deepest thanks to our esteemed speaker, Dr. Chamazdar, who shared his expertise, knowledge, and innovative perspectives on how artificial intelligence is revolutionizing diabetes care. His insights into how AI can aid in early diagnosis, personalized treatment plans, and improving patient outcomes have been truly inspiring. The real world examples and case studies you shared have painted a clear picture of how technology is transforming the healthcare landscape. To all the participants, your active engagement and the thoughtful questions added great value to this discussion. It is through such interactions that we can collectively brainstorm ideas and drive meaningful change in the healthcare system. In closing, let us take a moment to reflect on the importance of adopting innovative technologies like AI to tackle pressing health issues such as diabetes. Together with collaboration and shared knowledge, we can make significant strides in improving the quality of life for those affected by chronic conditions. Once again, thank you to everyone who made this session a success. Wishing you all continued learning and inspiration in your journey to explore the intersection of AI and healthcare. Please stay connected. After a few minutes, the next session will start. Thank you, everyone. Good night.
Thank you. Thank you very much. So shall I leave with your all your permission? I can leave. Then.
Yes, sir.
Thank you.